which is live case, and with two cases. I was designed recently as a chairman.
Yeah. Once more, congratulations.
I'm very happy to be with Robert Gill, Professor Nair from Cleveland Clinic in USA. So,
yes.
And I see, yes, Detik Privilovic from Croatia. So, can you, sorry.
Maybe we can start with...
Your name.
Chilingirov.
Yeah, Chilingirov.
Yeah.
Good?
Exactly.
A typical Bulgarian name.
He will present the two cases waiting for the connection with the cat labs. Okay?
Okay. Hello, everybody. So we are starting with the first cat lab. Professor Rigatelli and Professor Gelev will perform the case. It's about a young female who came to us with high-grade stable angina with typical risk profile. She's a smoker, has hypertension and dyslipidemia. She has known coronary artery disease, and half a year ago, PCI of the right coronary was performed. Also, severe LAD bifurcation stenosis and moderate left circumflex stenosis were observed, and she came to our clinic. She has no STT changes and has normal echo. We did an invasive assessment, and as you can appreciate, there is a patent stent in the mid-RCA with moderate stenosis of the ostium of the right coronary artery and also a diseased PDA. What about the left? The left is also diseased, and you can easily see that there is osteo involvement. Maybe the ostium of the left coronary artery was traumatized during the previous diagnostic angio. And we can see osteo lesion of the left main, some moderate lesion of the left circumflex. And from the cranial projections, the involvement of the left main, but also the significant stenosis of the LAD with the first diagonal branch. Can we switch to the next case? The next case will be in the second cath lab, and Professor Vasilev with Dr. Nenov will work on it. It's about a 67-year-old male with high-grade stable angina and known three-vessel disease. A month ago, PCI of the right was performed. Patient has also ischemic stroke in the past. No significant STT changes, no severe valve lesions, normal echo. And this angio, patent result from the right coronary dilatation with some diseased, maybe PL branch distally. And from the right image, you can appreciate the tortuosity and calcification of the left system. Maybe moderate stenosis of the left circumflex, calcium, and moderate to severe stenosis of the ostium and proximal LAD. And this huge diagonal branch, which is also diseased, and there is significant stenosis in the bifurcation of this diagonal branch. So that's the case presentation, and maybe we can contact with the cath lab.
It would be better to be with number one.
Yes.
Gianluca?
Cath lab, are you hearing us?
Valerie, Gianluca, how are you? Well, so we have seen the presentation of the case.
Добре, още 1500.
имам
Някакво
за
ретро, ако може малко водичка, за аз обичам да съм къпа, да ми е мокро.
Alors, back to the first one. Can we stay in this room? Have you injected already the left coronary artery, Gianluca? Do you hear me?
Cath lab 1.
CatLab 1, Gianluca? Valerie, do you hear me?
So, George, Yves, can you hear us?
Yes.
Now we
So, we have the setting, and what we have done, you know the case. Jean-Luc has already cannulated the right coronary. We have a wire down stream, and we are going to show you the angels with the guiding catheter. Can we play this?
All right. I'm sorry.
What you see here, this is.
We don't see anything for the moment.
Can you see the
Yeah, we see the angel now. Yeah.
Yeah.
We shot another one before. More clear. There is no record. We can shot now.
And we have already put it on NIVUS. This is to evaluate the osteo lesion of this vessel. And shortly we are going to show you the IVUS examination. Now we are going to.
You have to show this guy when it's
We're
ready.
going to make the angel.
No, not now, not now.
Are you
Soon.
ready for the angel?
Yes.
All right. So go.
hear her well.
Ah, yeah.
So this is this.
This is the angel with the guiding catheter not too deep inside, so you can appreciate the sinus of Valsalma and the ostial part of the vessel. There is a stent, an old stent below the proximal portion of the RCA. And for us, the lesion is short, but quite significant. And from the IVUS, now Akiko will show you the IVUS findings.
Sure. Can you take the, okay, good. So this is
cool.
can you see the IVUS?
Yes.
Yes, okay. So just go through. This is an old stent, which is nicely open and not much neointima, and that's a mid-right coronary artery. And this is already outside of the stent, so let's review together. And this is 52 years old female, and you see the nice plaque. And starting here is kind of normal, but you see the media is actually sick, so I indicating some sort of the spasm. That's ostium. And then we go out. So you see the very, very focal stenosis in the osteolite coronary artery, but I do think there is the very thickening of the media. So there is, you see, when I stop here, you see the media is thicker than usual what we see. That's indicating some sort of the spasm. So, but even though if I go to the ostium, it's very tight, and if I measure the area is, okay, yeah, looks like disappear. Anyway, it's very tight, but, and very soft plaque, and only the focal, and only the ostium. So to me, this is significant in relation to the angio, but I worry how much spasm effect of these findings.
But this angel is done after we inserted some.
Okay. If so, I think this is we consider significant. And if you go to the distal measurement, media to media is about 3.4, and this one is also 3.3, and this is media to media, and maybe 3.0 is a good one. And from here to the a little bit outside is only 6 millimeter. So even 8 millimeter or 12, that's a good
I
number.
think there's a 3.0 by 9 or by 8 something. Stent,
But I have because the stent.
Or
is,
because there is a-
we can
you-
overlap the stents.
yeah.
Oh, no, you don't have to. If you go to the stent to overlap, it's going to be, okay. So this is the old stent segment. So if you cover everything up to the ostium, it's going to be like 22 or 23. And in between is not much disease. I don't think you have to.
What do you think in the panel? We should go for cover up to the older stent, or we just cover the ostium and that's all?
I still believe in focal stenting.
Dr. Nair?
Yeah, what length are you going to use for the ostium? 8 or 12?
You said
Because from from the lesion itself, it's
was
about
made move.
6 millimeter by a Kiko.
Yeah, but that is so, you're making a very fine judgment, you know, so you will have to get one strut maybe outside the right, and my
No,
only
they-
fear is that you might possibly miss the lesion if,
Leti?
I don't see the measurement.
Lesion
of
is
the-
6. Lesion is 6.
Six.
And
Six something.
Akiko propose 8 millimeter stent.
I will choose 12.
well,
I will just say that it's depending of the what you will do to be sure that it's not moving.
right.
So
Yes.
personally, I will use the classical technique of putting a wire in the aorta.
Oh, so you
Yes,
could do that.
that was my next
But I will,
question. What do you
I-
think about the
If you
second
do
wire
this,
in
you can put 8, in my opinion,
8,
safely.
yes.
But put
putting
10 or is not a problem. And personally, I won't go to the video stand, which
Yes.
is in normal.
I think 12 is a
Jean-Luc?
good
There is
option.
also always problem with the preparation of osteal lesion. Theoretically, this is soft
Right.
plaque, and
Yeah.
we shouldn't expect some slides of the stent, but anyway, I would predilate it
Yeah. I
just
think-
to be sure for this 8. If not, I would take 10.
So Robert want to predilate this lesion, and personally, I will of course predilate, but I will also put a wire in the aorta to try to immobilize completely the guiding.
Yes.
So you put a wire in the aorta and you push on the guiding. So you are not inside the lesion and you are not away from the osteum.
But if you want to make it simple, then use a 10 or a 12.
Yeah, of course, of course. But the problem then can be also you can stand inside the aorta. That's
Yeah, right. You don't want to
so
do that.
having the wire, I think, is a good.
Okay, what is
something
your
simple.
choice, Gianluca?
But to put a wire inside the aorta is not my preferred technique for osteal lesion, but if you wonder, we can put it. I have some concern about pre-dilating or not, because by a Kiko, the plaque is very soft, so maybe, isn't it? Maybe that we don't need forcefully to have to pre-dilate. What about you?
I will go for direct stenting.
Yeah.
That will help us to keep the stent in place.
Correct.
But
Yeah.
take longer than 8.
No, but our compromise is to take something 12 or 15 to stay on the safe side. Otherwise, it's going to be quite difficult. The idea was whether we are going to to put the stent and to overlap the previous stent, but
Yeah.
Kiko assures us that there is no disease and that's not necessary. So we are going to take a shorter stent,
All right.
not overlapping, but not extremely short.
But you are going to post-dilate, correct? If you're going to post-dilate, why don't you just use that balloon to pre-dilate?
I don't understand, sorry, repeat.
No, you are going to post-dilate with a
Going.
non-compliant balloon, correct?
Going.
Yeah, maybe,
So,
yeah.
so then
Probably
you,
yes, for
so
sure.
use the same balloon to pre-dilate. Why
But
very?
me and Valerie are of the opinion to do not pre-dilate, just because the plaque is very soft. So we go for direct stenting, and then we post-dilate after.
So
also-
kindly discuss what the downside is in pre-dilating.
I think his message is that if you put a stent without pre-dilatation, the stent won't move. You know,
Oh,
like
I see.
pre-dilated. You know, that's the idea. I
So
think.
that's the downside. You think the stent will move.
Leti?
I just wanted to comment
Sam.
the post-dilatation with a non-compliant balloon and
Pull it out.
put it out in the aorta.
And flare
then
it.
There is
Correct.
also an additional point which is pre-dilatation, because we have to optimize the result. We don't
Yes.
see the real size of the vessel right now, because there is also a part of spasm, all of the things. After pre-dilatation and just short IVUS inspection, we could expect to assess the real size of the vessel. The other point is very interesting, how we should optimize this stent implantation. If we don't want to touch the already implanted and healed stent, we should rather take into account the lumen size. And based on this lumen size, we should optimize the new stent. Yeah. It's a very interesting case.
So this here, the gap is very short now. You want to actually leave a small gap.
This is 15 or 12?
15.
I think that we can go there.
So the gap is very small.
Okay.
Yeah,
I think we can
very
go
short
Make it
gap.
expand.
there. Yeah.
So,
I think we can go there.
okay.
They decided to do it.
I would like you to, Ivis, and show me the gap.
I think that if there is a gap, it's about less than 1 millimeter.
Yeah, yeah.
That's
Less
the
than
point.
1 millimeter.
Okay.
Yeah, 1
Inflate
millimeter.
outside.
So he decided to pre-delay.
You could have gone 12, and I don't like to leave 1 millimeter gap.
Yes, I think that's the risk of resting. all this
Gently
is
withdraw the
way too
balloon
deep,
without
Exactly. Now you will
overlapping and post-dilating.
seating the guide wire too deep in order to do not damage the ostial stent. Then we go for
Personally, I will keep this balloon, which is semi-compliant balloon, inside the
Yes,
guiding,
from the stand.
sure.
because this is the best way to optimize the diameter if the vessel open, which is not the case, but apparently.
I think that the osteo is covered.
Yeah?
It's
Yeah.
pretty good. Now we post dilate with 3.5.
No, 3 to 5. 3 to 5
Yeah,
or
3 to
3
5 would be good.
Okay.
The pressure is...
All right.
Три 25 имаме. 3,25.
Now we wait for the balloon. We do not go too deep with the stent because I don't like to put 10% of the stent outside the ostium because afterwards we can expect some difficulty in regain the vessel. So I would like to be as minimal as I can.
So the stent was a T0, yes?
3.0, yeah, by 12.
So why using a high pressure balloon? I mean
Sorry?
a non-compliant balloon, why?
Because they give me this one, but
This
maybe also semi-compliant. In my
is-
cat lab, I usually use
Okay, it
semi-compliant.
is a
He's Italian.
soft lesion.
This
He
is
used to say the truth.
it's not depending on the lesion. A stent can be opened by 5 to 6 atmosphere, any stent.
Yeah,
So
sure.
the problem of a non-compliant balloon to have to go to high pressure is to treat the wall, not the stent.
Yeah, I agree.
So here is soft. You use the balloon you use to deploy the stent, and you go up if you want to have a half millimeter more.
Yeah.
Yeah, I agree.
Sometimes
But,
with the right coronary, you can use what is called ostial flash
Yeah.
to get optimal deployment of the stent at the very ostium. Because sometimes the ostium is like a funnel.
It's a bit deep, I think. Pull a bit, high pressure.
This is 3.5.
Yeah, this is 3.5.
3.25.
This is probably the good.
We flare a little bit.
Yeah.
Yeah. Oh, yeah.
Then you can push the guide down and
Okay.
push the guide up. And there's almost no gap, it looks like. Maybe Ivis will show us. Watch the guide, it's going in.
So what I will appreciate now is to see Akiko show us that you have a remaining proximal part of the artery which is not stented.
And maybe
Right.
now
By the
We will
way,
see.
by the
We will
way,
see. We
I,
will see.
I saw, I saw the
1 millimeter
internal
gap.
movement of the stand.
This
Yeah.
I
So
saw it.
Akiko will tell
I
us.
saw it.
Akiko
No,
will tell
I
us.
can
Yeah.
see.
and then we do the IBUS and we have all the
I think you
answers.
can see a little narrowing.
Yes, yes, we are waiting for.
You are right.
Секунду. Устойче се чупи.
Always for ostial. This is for me
Stop breathing.
mandatory.
Yeah.
Predilation.
Yeah. I
You
think
should
so.
go back to the original position.
Even with
Push
uh,
the
this.
flash?
this
Yes,
vessel.
push, push,
Yeah.
up to the
I
end.
would put that in.
Thank you.
There
That's
is
good.
no harm.
Okay, should be
The
flash.
ostium, you know.
Oh my good. When I fly.
Anyway, it's better that it was.
Almost blind.
May I ask you if just any contact with this case, but if you have the case when you didn't, let's say, cover the ostial, the ostium, just
more?
1.5, less than 2 millimeters, and you have already, let's say, implanted stent, what do you prefer?
Okay, that's
to leave,
enough. Can we start?
let's say, to stent,
Yes.
to use additional
Yes.
stent, or just waiting for restenosis and drug-eluting balloon? What is your strategy?
I'm not
We
sure
have the
that
IVUS.
drug-eluting balloon will work properly.
We have
on
the
this
IVUS
position.
inside and we are
Personally, I will
doing
say-
the pullback.
I will put a second stent.
Okay, so this is the old stent segment.
We hold, okay. Let's see if there is overlap or if there is a gap.
I think this is,
This is one layer.
yeah, I'm not sure this is old or new stent. Okay, are you putting it back? Looks like,
I think this may be old because it
No,
looks
you
like
are
there's
in
some
the older
material
stent now.
inside the stent.
okay, yeah, still old stent, which is not much neointima.
Yeah, at 9 o'clock.
Yeah, there is some.
Okay, still old stent,
We don't see 2 layers.
old stent.
Here, this is old.
I
This
don't
is
know.
old. This is old.
Yeah.
It looks like
now I
this is-
see two
this
two
is-
layers.
Yeah.
2 layers.
Yeah, perfect.
So it's
Yeah.
overlap. You want it
Overlap.
overlap?
I think
And the ostium?
it's okay, but I hope you should protrude a little bit more. What do you think? Oh, this is
We
perfect.
protrude a little, just a little bit.
Yeah, what do you think? I think
Very minimal.
Sure. Number one, there is a clear overlap. There is no gap. Number one, right?
Yeah.
So I think somewhere here, this is old stent, and then few, this is not yet, not yet, not yet. Yeah, here is a little bit overlap like this.
Two layers.
Yeah. Then come back. This is a, okay, here.
So that's not
this-
covered.
Not covered.
This is the ostium?
That's not covered up. Yeah, that's
Yeah,
not.
that's how much it is? Half a millimeter?
Yeah.
I think it's okay, but I hope you have two strata
It's less
more
than
in
two-
the
this
outside.
is less than 2 millimeters.
Because original region was really here. Oh, sorry. Oops.
I think that the original lesion is covered.
Yeah, it's
What
here.
we do not cover is the roof of the
Yeah, you are right.
of the ostium because
Yeah.
the artery is not is downward.
Yeah. And the minimum stent area is 7. I
Yeah,
think
but
it's
I think
okay.
stent
Yeah, this
itself
is
is
already
good.
part of the
Yeah,
outer.
yeah.
I
Okay.
think
We'll
that
leave
is
it.
okay. It's a minimal
Yeah.
protrusion.
It's protruding, in fact.
It's not
Very minimal. We
I
do
mean,
not
the
cover.
ostium is,
Let's
downward,
believe
so we
that,
do not cover
that
the roof, but it's
Okay.
okay.
the diffusion of the drug will
Yeah,
do a
well,
good work.
Yeah, it's like a stent.
Yeah, but not proximally. It has been shown. It has been shown.
Just a little.
I remember.
Just a little.
I remember a paper showing that you have some elution of the
Distal.
drug stent
With the
distal
flow.
to the
Yeah,
to
well,
the
with
strut,
the
but
blood
not
flow.
proximal. So
We do a final angio AP, Karen.
you know, at the time of balloon angioplasty, not all the lesions were stenosed. You know,
Yes,
Right,
some of them,
right.
some of
At
them were.
least 30%.
Yeah.
Anyway, this is a very,
Okay,
very
the
short
other
ring of not,
And then,
let's say,
at the
without
cranium?
a full coverage.
Okay.
If we start to improve it with redilatation, we can induce let's say the
Injury,
hyperplasia.
Yeah.
So I would leave it because this is 7
And you
square
have seen-
millimeters.
you have
Is
seen-
fine.
This is a bit oblique, so
Oblique, yeah.
one,
I
one
think
part
that
of
is
the
no
is
bad.
covered, was in other one is not.
Yeah.
I will leave it.
Oh, so I will leave it like this. Yeah.
Yeah, for sure. So we remove a wire and we jump to the left system, where we have to do another HIVUS because there is
Another ostium. So
Still
yeah,
LED,
there is an
We
osteal
see
disease
sometimes,
and an LED disease.
I remember cases with ostium right, ostium left, ostium renal, both renal, which is, I don't know if it is a specific disease or not.
Може би
Special composition of genes,
Yeah, maybe.
ostial genes.
But she had a stent in the right a few months ago or last year, right? The RCA stent.
So, what kind
I don't
of
remember.
guiding?
Enable 3.
Yes,
But the
last
lesson,
zero,
but
choose
to,
because
to
of
young,
the
to young
2.0
people,
exit.
the lesson of this first stent implantation is that
we-
you have to be completely sure
We go
that the
straight,
material
AD.
to be covered by the stent is very soft.
I will do.
Otherwise,
Oh,
always predilate osteal lesions. Always, always, always.
So her RCA stent was just last year. So if you were to wonder what is the mechanism of the osteal lesion, you might say number one, that there was some mild disease that grew worse. The second is that you traumatized the osteum with a guide
Yeah,
catheter
yeah.
while you were doing it, and then it got worse because the lesion is extraordinarily soft,
Yeah.
not
yeah.
fibrocalcific
Yeah,
at all. Not that it makes a difference in terms of treatment, but when you look at the mechanism. So what guide are you using?
All right.
EBU, I think.
Like yesterday you were,
Yeah.
you had a case of
No, it's тук да стои за пръскане.
the other lab.
Yes, Gianluca,
Yeah?
and we will move. We'll
Yeah.
move 1 minute in the other cat lab just
Sure.
to see what they have found at corner angiography.
All right.
So we are back soon.
Okay.
Okay?
Жвачката.
Yeah. So Dobrin,
Rotational lateral stuff.
Dobrin, we discovered that you are doing rotablator when we were looking outside. So, okay, explain. Show the pictures you did and your strategy.
Okay, so this is a patient which, you know, better than me, probably.
Ah, that's.
So this is a patient with the previously stented right coronary artery, which is a huge, with the previously stented right coronary with the, this is 3.5 or 4, 3.5 stent. And the patient came for this proximal LAD, very tight stenosis. And on the next projection, you can appreciate that there is a huge amount of calcium, even on without contrast. I tried to do IVUS on this, but it was not successful. Actually, the IVUS catheter stuck into the lesion. And I would like to ask Dr. Stoyanov to assist. Yes, Dr. Mahara is here. And this is the pass from this positioning of the IVUS catheter. So, in the meantime, we assess the IVUS. I would like to ask Dr. Mahara to comment this IVUS finding. And during that time,
I think there must be left main disease, Dobrin,
Anyway,
because the left main seems to
Did
be the
somebody
same
check
size
the
as the
IVUS?
LAD.
Yeah, that's a good one.
this is a place where the IVUS cluster stuck. You see the
But
180 degree of the
we don't
calcium
see
here.
IVUS right now.
And that's the proximal LAD.
We need
And
IVUS.
then come back to the left domain. This is jump.
Can we see?
And this
Can
is
we see
also
IVUS?
We don't
180
see it.
Can we
degree
see
of the
IVUS?
calcium.
We don't see
really couldn't
Akiko.
see the region, but I think indicating at least from there to ostium is all calcium.
yes.
Can we
So-
see again the IVUS? We have not seen it.
Can we see?
Dobrin.
Okay.
We
Show
see your head.
show us.
We see your head, Dobrin. Yes. Okay,
Okay,
now we
thank you.
see the image.
Yeah, okay,
Yes.
so this is the left domain. You see the 180 degree the calcium. And then go to the proximal LAD. This is also 180 degree of the calcium. That's it. He couldn't pass more distally, which is a region.
What is the size of the left main?
Okay, size of the left domain, sure. Go back. This is how it looks like the left domain. And then diameter of the left domain medial
This
to
is
medial.
proximal LAD.
No, I think this is left main. 4.3. Yeah.
But the lumen area is what?
Oh, do you think this is proximal already?
Yes, I think that this is a very proximal because the circumflex is.
No, oh, you are right. Yeah, probably my mistake. Okay. Let
Okay,
me
so
double
that
check.
area is good.
Yeah, let me double check. So,
This is manual pull back. Hop.
yeah, I think this is going to be the guide. So that's a left main, looks like.
This is
right?
left main, yeah.
Right? And then this is a left main. And actually, this guy is the circ, which jump. And this is a proximal already.
Exactly. that
Okay,
was
so
the-
then I think the question to you, I think I measured the left main, which is actually 7.3, which
Yeah,
is not significant.
that's good,
That's
yes.
good to know.
Yep. So we made.
What's your plan?
My plan is. Can we remove it?
That was 1.5 Burr.
Yes, that was the.
So Dobrin, it was 180 degrees calcium. Why did you decide to do plaque modification? Were you convinced it was more? I'm just asking. I'm not questioning.
The plan is actually to do the initial plan. Even yesterday we bet with Valery. I said that IVUS will pass, and he said that it will not be possible, and actually he was right. And I was not able to pass with the IVUS.
Yeah.
So I just made rotablation with 1.5 Burr at 160 RPM, and it was not so easy to pass, but gradually we were able to cross the lesion. Now we will do control angio with Dr. Nenov, just to see the result after just to see the result after the rotablation. I think that we have even on angiography a visible crack of the lesion, so I will leave the rotawire on place, and we'll place secondary wire run through, and we'll try to do again IVUS, and I will ask Dr. Maihara to assist me in the interpretation. Run through.
Dobrin, why only short runs? Why not more runs
exactly.
with the atherectomy?
Sorry, I didn't hear you.
Why not make 1 or 2 more runs with atherectomy? Or did you already do 3-4 runs?
They do IVUS anyway. Don't worry.
Because at the end of the polishing of the
Yes.
Was just for
you
for
can
IVUS, I
appreciate
think.
here
Yeah, you
Just for
did.
IVUS, you know.
Yeah.
that
cross with IVUS.
actually after that I made a final polishing run.
Yeah, but you could have
We
gone this.
will see. Just
Yeah.
now, just
know,
I
because-
think in 2 minutes we'll
Yeah.
know
What's happening?
what's happening. Yes, and
But usually, if there is no problems with the rotational atherectomy, you've already paid for it. So why not just use it?
Yeah.
Because the diamonds are still good.
now we'll see.
Yeah.
If the IVUS pass,
Yeah, if not, now you have to do rotational atherectomy again.
IVUS.
So
If
generally
the-
with rotational atherectomy, you can do injections in between runs and you look for problems like slow flow, perforation, dissection, then you stop. But if everything is okay, the patient is tolerating it, you can make more
Ravi,
runs.
but you know, I know Dobrin longer than you.
Yeah.
He is minimal,
Impatient?
minimal invasive interventional cardiologist. So he believes in balloons, in
The
stents.
patient is stable. The
Right,
blood
so
pressure
then-
is stable. No changes in ECG. No
Yeah, so then do it, no?
signs
Yeah, sure, but
of ischemia.
let's finishing this one.
Can we see IVUS?
Yes.
We have it.
That's a left main?
Yes.
Okay, go ahead. Left main is super clean, by the way. Oh, I see the
So,
lesion. Okay,
Dobrin,
okay.
We
now,
look,
good.
we look the
Okay.
IVUS, and after that we move to the
Okay,
post-cath
can we
lab.
start pullback?
Ravi, I think that that's enough for the strategy.
Okay.
Pull back slowly.
Okay.
But what
Okay.
if it didn't go?
This
then
is
you-
normal
just
segment.
only plaque
Pull back.
modification without plaque
Good.
debulking.
This is a diag. And still we are normal.
We cannot see.
Dobrin, can we move?
And
We
this
don't
is
see.
a soft plaque.
We
Sorry.
don't see the IVUS. Yeah. Okay.
And we will show later, don't worry. And this is still normal. We are talking the distal region. We didn't see the main region yet. Come back.
No.
Come back. And that's a septa, which is disease, interesting.
Yeah, so you
And
had
that's a
good
major
landing
region.
zone.
And actually soft. Okay, okay, I see.
It's the
okay.
same. The
This
plaque
is
looks,
proximal
the
to the
calcium
lesion.
looks the
Was
same.
polished,
more.
huh? No?
And this
Yeah,
is sarc,
but
and this is
there
the
is really a
left.
very
Okay.
short
Sorry.
part of the calcium
guys, let's see.
ring.
So, Dobrin,
One thing you should appreciate that the vessel proximally is extremely tortuous, and during the manual pullback,
It's a jump.
it jumps exactly at the ostium of the LED. There is a more than 90-degree curve there, and it is very difficult to
Okay, do you want
assess.
to see divers together?
Okay,
With people?
let's- yes,
you have
please.
to a little bit.
Dom-
Okay, so can you see divers?
No.
No?
Now,
yes,
Now
we
it's
can.
good.
Yes?
We can.
Okay,
Yes.
good. Okay, so this is super distal, by the way. And this is a pericardium. So if diagonal should be this way and septal should be this way. So let's pull back from super distal. And this is completely normal. This is a diag, which is super distal. And this is a normal segment, which is nice landing.
So
and
that's a good landing zone.
Yeah,
yes.
this is soft plaque and some calcium
Yeah, this is-
and some disease, but this is also normal. So I think maybe we can stop here. We discuss,
Yeah, you
right?
can start
If
here.
we stop here, this one is media to media is going to be. Oh, sorry, this is mistake. Sorry. Media to media here is going. Don't worry. Let's do later. Okay, go more proximally, and then.
There is soft plaque there.
Yeah, still this is okay. Okay, so this is
is
exactly the region. So this is a septa, which actually ostium is calcified, interestingly. This is a LED and also calcium, but not too bad. And then come back. And this is exact region, but still the calcium is only 180 degree from here to here. And then more proximally, interestingly, this portion was actually soft plaque. And then where you have stuck on the catheter
Yeah.
is here. This
So
is
we have
the
to do-
place where you have stuck. But actually, not too bad. You see the calcium is only here to here. It's only 180. So I don't think you need more rotablator, just making the good balloon, and this is okay. And that's the place you stuck, right?
Yeah,
And then you polish the surface of the calcium and then making the loom. And then we go back to the proximal. This is what we see before. This is the proximal LED. And then come back. This is a circumflex, and this is a left main. So I think the recommendation is starting here to land. But before, you should make the good ballooning this portion. And how big the diameter of this portion is media to media is about 3.4. So maybe 3 or 3
3
to
or
yeah. And that's number one. And then actually only that's the calcium and then soft plaque. And then some 180 degree calcium. This is septal. So you should land just distal to the septal. And this segment is media to media is still 3.3. So 3 or
3 or
yeah,
will be okay.
that sounds good.
Yeah, I had a question about the ostium of the LED, why there is echo dropout.
Okay, which one? Okay, come back. This is
Yeah.
osteo LED.
Right.
You're talking
That's
here?
calcium.
I'm sorry, you're talking
Yeah,
here?
right there. Why
I
is-
see.
Yes,
Okay,
why
so
is there echo dropout?
Yeah, sure. Because this is too close to the IBUS catheter. This is so-called near field gain. We cannot differentiate any information. But I do think this should be the protruding calcium.
Yes.
So I think this is a place where he stuck.
Correct.
But I think now is ready just non-compliant balloon well, and then making the stent 3 from distal to the septal to the proximal LED. That seems to be good enough.
Okay, Dobrin,
Trin advice,
we will
balloon
move to
NC.
the,
Trin
to the
advice.
first cath lab for a few minutes.
NC. Къв ще да е?
Okay, let's see. Sorry. Can I
We
see?
are here.
Yeah.
Gianluca, Valerie, we are here.
Gianluca.
Yes,
Please go ahead.
we can hear you well.
So what have you done since
We,
few minutes?
Gianluca, please.
So we cannulate the left system with an ABU
Can you show?
3.0, 6
Can you-
French.
Can you show the angio?
Yeah. Yeah. I like Valerie because it's much better than me.
Okay.
So we have the
Yeah.
proximal, the osteo left main, which is highly diseased, and this probably severe lesion. Akiko going to
Have you
confirm- to
another
confirm that.
projection?
And this is the IVUS. We can do one caudal.
Yeah.
And during the...
Because I remember it was a very short left main. So I think we can
Yeah.
discuss this problem with the panel here. You see?
Okay, can we
We
see
put
that?
a third wire into the LCX because the left main is so short.
Yes.
And we plan to go if Akiko
Okay,
let
so
us.
let's review the IVAS together.
right.
Okay, so this is a very distal LED, and by the media to media is 3.0. So let's review together. There is some calcium that's okay. So this is by the way septal, and then this is a big diag, second diag, and then more. And so this is a very severe disease. This is a mid LED. So
Yeah.
this is obviously disease. But you see, majority of the plaque is attenuation, no calcium. So this is actually soft plaque, right? So go distally. This is wired, your proximal diag.
Uh-huh.
So first diag, and there is almost twin diag. So this is diag, and this is one more diag, right? So your lesion is just distal to the first diag, right? Okay, that's number one. And then come back. Proximal to the big two diag is vessel get bigger, and then it's actually in between is okay, nothing. And this is a circumflex.
Yeah.
And then we come back. This is super short left main, and here this is the ostium the left main. I think this is super severe. Minimum lumen area is only 2.1 square millimeter. So I do think that you should do two separate things. This is the osteo left main you should cover, and then cross over to the circumflex.
Yep.
And then somewhere here, that's a good landing. And the media to media is 3 points. So I think that's going to be 3.6, 3.3. So 3.0 or 3.25, that's kind of stand. And if you come here and then cross over to the circumflex to protrude left main is about 14 by IVAS, that's number one. And then in between there is nothing, not nothing, but not significant stenosis. And this is your first diag. So I think if you start, well, you may want to connect it all together, by the way. I thought so. So this is the proximal to the bifurcation lesion, still the media to media same diameter. And this is your first diag, and this is your second diag, and this is septal. And after those multiple branch, your vessel diameter is super small, it's only 3.0. So one,
This is media to media. That means we have to
go down 2.5. So if you connect all together from the beginning to the something proximal LED 36, okay, what do you think? Looks like two separate regions. And also the vessel diameter is completely different. So using 3.0, only the left main, one, and then concentrating distal, because your landing is distal to the trifurcation, and the vessel is media to media 3.0, so you have to using the 2.5 or 2.75.
So
What do you think?
you propose to treat
And
first the left
why not
main
use
and
one
then
long
ADD?
stick?
Yeah.
No,
Because,
but
yeah.
Yeah,
we have
that's,
to gel
Maybe
the
after
wire.
one long
the-
station.
the-
Yes.
yeah.
Oh, circumflex,
Yeah.
gel the circumflex.
You can use a very long stent. Are you far from the left main?
So probably we should treat
You
the
should start with the LED and then
and if the diagonal is okay, remove the wire. Otherwise, into the left main we will have two gelled wires.
You know,
Okay,
I
okay.
would suggest you to check the let's say the bifurcation circumflex and left main, because I saw a kind of calcific plaque, let's say, in the orifice of circumflex.
Let's predilate.
And so you have to predict the technique not to lose a big
And-
No, osteal
circumflex.
sac is clean. This is osteal sac, no calcium at
we
all.
don't.
But
No.
look,
But,
I mean,
what
we
do you
have three
propose,
wires.
Gil?
One-
Because, Robert, because
just show it. Just could you give me closer?
was-
Closer. You see that? Just go back a little bit.
Go back distally?
Just a little. Yeah, but look, and from distal to proximal, and then you will see
Okay.
that the plaque from 12 to 3, it's coming.
Which one would you like? Okay, this is good enough?
To the
It's
left
in the
or right?
direction of left main ostium.
Okay, so this is, I'm putting back from distal to the proximal.
yeah.
Okay,
Go farther,
That's
farther.
Yeah, so
And
this
look,
is
you
the
see?
circumflex.
You see that?
Yeah,
You see?
nice bone.
which one?
Okay, now it's fine.
yeah.
That was just before
The left
ostium.
circle is
It's
fine.
good. It's free of
Yeah.
calcium.
No
So,
calcium.
what do you plan exactly? Gianluca?
we plan
Valérie?
to fix the LDA first because we have to jail three. Otherwise, we have to jail 2 wires. This is not hygienic. So we fix first of all the LAD, and if the diagonal is good, we remove the wire, and then we concentrate about left main, and we plan to go crossover from the ostium to maybe connected with the second stent.
Yeah, I think so.
But
right.
why not one long stent? Crossover, one long stent?
That's also possible. Distal is 2.5, and then the left main is actually 3.0. It's
But
Yeah,
not.
so you
we
can
have
put
to
it-
go into the left
30,
main around 4,
36.
and if
Yeah.
you
No,
put
no, no,
2.5,
no. No,
what is the...
this patient left main is not super big.
Not
This
that
is
big.
left main. You see?
You can put one long stent and post
How much
This
dilate.
is
it is?
3.0. Oh, wait. Okay, this is a
That's
left main.
awesome.
Yeah.
Yeah,
this
that's
is third.
left main.
So I think that even left main is medial to medial 3.1.
Yeah.
The
you
lady
can put
here
on
has got a small left main, I would say.
Yeah, I'd
because
say
it's
too.
3.1 something.
Yeah.
So yeah, we can go also with one single stent, but there is still the problem that we
With the
jail
jailing of,
2 wires. That probably is
That's
not.
okay. Before
is not
post
good.
dilating, you can remove the wires. They will come out.
Yeah, if everything is 44.
The only problem with 2 stents is that you may overlap over a diagonal.
So I can bet that after pre-dilatation, you will see the increased left main size. Can you bet with me?
No, I think
let's,
you can overlap
Yes,
proximal
but
to
up
the
to-
dial.
For
You
sure.
have enough
Up to
space.
4.5?
No, there is enough space,
Yeah.
I think, from the...
You know, if
I
you take-
don't believe in this
diagonal,
3-0.
which is very...
If you take a
Yeah.
balloon which is a stent which is 3.0, you can go up
You
to
can go- you can
4.
go up to 4.
4 millimeters.
So we suggest to pre-dilate with 3-0 and reanalyze with IVUS
Yes.
the left main size.
I mean, you do what you want, but I think the long stent
go,
makes more sense. You don't
right,
want to
diagonally.
overlap stents over a diagonal because then if the diagonal is lost, it will be very hard to get into it.
So now we go for pre-delayed lesion LAD.
What is the
Engage a
balloon?
little bit
Three-
if the pressure
ahead.
allows
2.5?
me. So, yeah, just
Gianluca, this
Yeah.
is 2.5?
is
2.0.
2.0.
2.0, okay.
We just inflict
Very
the
non-invasive dilatation.
Yes. I
flash
will choose
2.5 at least, huh?
maybe
please.
there. Okay. Pretty. Inflate. 12, 14. Okay, 16.
You know, in the era of thin strut stent, the overlapping is not a big deal. And then if you really have a very longer than 40 millimeters lesion starting
This
from the
is,
left
15
coronary
millimeters.
artery ostium, you have to be very cautious and you should reanalyze, reassess let's say the size of the vessel, especially proximal part after the pre-dilatation.
Was
So
it
you-
3.0 distally by IVUS?
2.5.
Was
2.5,
2.5.
Can go even there.
So you can put a 3.0 in fait at 6 atmosphere,
And then-
full, in fait high pressure proximally.
Okay,
Yeah.
stop.
And with the 3.0 you can go up to 4 probably,
Yeah.
depending on the stent. So if the vessel, the left main is 4.5, yes, it's a bit small.
2 stents cost more than 1 stent.
But we,
Okay.
in Europe, we need perfection.
Just to
We don't care the money,
inject.
you know.
Is that right?
Especially in developing countries.
Yeah.
Okay.
Is there something new or not?
So 15, it means that from there,
Yeah,
to
something
just
right.
yeah,
Mine is
324.
4.
Yeah, it's
3
much
or
better.
2.5 or 275, I think.
Two-
Because she
2.5.
measured it.
Three.
Too long.
3
for one.
medium to
2.75.
Maybe too long.
Akiko?
Or
Yeah.
2.5
This is
75.
measured 38. You can
Or
40 millimeters. stent. Anyway,
2.75 possibly okay, but we didn't see anything beyond this segment. But I think
Yeah, it looks-
2.75
it
maybe
looks
okay.
very low.
Yeah.
Or
She
2.5, we
measured
can always increase, but we cannot
36.
go.
I'm sorry,
It
what?
looks more.
I mean 2.5
2.5
probably
is
because
safer
we can
because
always
we don't-
increase,
yeah.
go step up, but step down. And it is very important to respect the distal diameter
Yeah.
because
Yeah, yeah,
it is
okay.
important
Yeah.
diagonal. 2,15 23
So this
more
does
than
tend to
40
going to starting
Yes,
point of
this
the
is,
IVAS to like 10
down to
millimeter
cooperate.
proximal to
Yeah,
the
there
first
is, there
dial.
is a landing zone that angiographically appears to be quite healthy.
Yeah, I think that's
Emmanuel
IVAS
already
can
left,
too.
or-
But I think you need a
Yeah.
pot proximal to,
Sure.
yeah.
No, he's.
So
he's
you
at
need
the
enough
hotel.
legs,
Okay.
right?
We do a pod, and then if the diagonal is good, we remove the wire, we
sounds good.
concentrate about the other.
Discuss this in
So,
one
On the
meeting.
same page.
Gianluca,
Yeah,
he's-
we
he's
are
at
going
the
to put the stent now. We choose
Can you
a
join us for
2.5
dinner or
by
No,
No.
what
he's
is
leaving.
23.
Taxis at
22
6.
3.
that's for distal
23
lesions. That's
from
for
the
distal, for LED only. Yeah?
Sorry?
This is for LED only.
Yeah.
Yeah.
This is
And after
for
that,
LED.
you put the stand from left main to LED. Yeah?
Yep.
So what is this length of LEDs?
26, you said 26 lengths?
23.
23 by 2.5. Yeah?
Yep.
But I think with a semi-compliant balloon instant,
I'm sorry,
you can
what?
play on the diameter. A stent is open at 6, you know?
Yeah, more
Fully
like,
open.
yeah.
So you can, but the diameter is not the 3.0, this is a 2.6.
You're right.
This is something I do frequently.
Sorry. Inject.
When you are especially doing the inverted provisional, going from the biggest to the smallest.
Yeah.
So the defensive diameter is huge, and
Really?
you have to use
Yeah.
this artifact
Has a little bit short.
Right.
to be able to cover the bifurcation.
I think they went
Let's
for
28.
You need the
Very
longer
patent advice,
stand,
No,
yes,
you need
it becomes
long, very
short.
much long there.
Probably there is
and
a...
the overlap
Sure.
will be over the diagonal.
You're right.
if they
This is
leave
what I
cover.
wanted to avoid.
Longer.
Yeah.
Too
could
short.
put a little-
It was
yeah.
obvious.
I would like to bring
Okay,
your
we change
attention to
for
the
30
fact that
or
the
28.
stability
We
of
change
the
it,
hemodynamic
yeah.
stability
no,
of this
it's,
patient.
Yeah.
No issue
So
to,
already adapted
make
for
compromise.
this left main stenosis. Hard to believe.
With the other stand,
Right.
we need some more length of
Yeah, but
the first one.
yeah, you know, left main is
we should
sometimes
go
it's very
deeply
stable, you
into
know.
the biggest stand
Because
into the bottom of the diagonal,
what we
which
practice
can
in
cause
Massif to
some
be
part
sure
shifting,
to
which
take
is not-
Yeah.
to leave the time to
still,
the balloon to fully open is to
Gotcha.
inflate 30 seconds
pet, not
one
vice
time
versa.
and a second time. If it's not enough, one time more. And this is also plastic, so the diameter is increasing.
Molto bene.
And I
Okay.
I'm sorry?
inflated frequently
Diagonals. It's high
30
definition.
seconds in
Yeah.
the left main.
Oh.
Never more than 20 seconds. So it's just a rule.
What I don't like at all is when
I
you
think
see
we
you
didn't
hear
see long enough
inflation
by
and
IVAS.
deflation.
10
That's the
seconds
reason why you
click.
see some discrepancy.
This is not open.
Yeah.
This is not
It
half
was
the
not
diameter. Yeah.
distal enough,
You have
probably.
to
Yeah,
repeat it.
by IVAS.
Okay, we are going to put, we change a little bit mind because we're considering that we connect
Yeah, we'll come back.
afterward the stand on left main to this one. We took a slightly longer one, 28.
Yeah,
so
that-
That's
it's
good.
2.5 by 28 in order to be facilitate to connect the stand on left main
Yeah,
with
now
this one.
we'll be fine.
So
And after that, you will do something on the diagonal? Just if necessary, we'll see.
I don't think that we need
Just protection, huh? And after that,
We
you will stand
protect
from you will stand the left
Ideal
main,
point.
yes?
Yeah.
We protect the, I mean, what appear to be the largest
No, this is
one.
because this is maybe the good time to go to the other room where
Yeah.
they have made the progress. So we are back to you to see the result of the stanting and deployment of the second one.
6, 8, 10, 12.
Okay, we change to the...
Here we are.
Theory of the sixth atmosphere, I don't believe too much.
By the way, I've just realized that we should calculate the real, let's say, size of the left main using Finel.
If you have two
and then we have
two normal
LED,
diameters,
we have LED,
you can do.
we have
Circumflex,
circumflex, so
yeah.
we can
LED was-
calculate.
was a...
318 something. Yeah, 3.
And the circumflex was also
They didn't measure.
Very similar, even bigger.
similar. So 3 plus 3, 6.
6,
2/3 of 6 is 4.
4.5.
So the finesse formula, this is
4.2.
much easier than the Murray's law. And even the Uokasab is is worse. So this is something a normal interventional cardiologist can do, even me, in the cath lab.
Дайте ми един
So,
3 на 22.
what are you doing? We are
I'm
back
trying to find the best projection for the proximal stent implantation, but it is
You want
not,
to where
not
do you implant?
easy, just because I will show you. This is just to show you where we were. Okay, so I made a predilatation with 2.5 to 20 millimeter balloon, non-compliant, at 15 atmospheres for the predilatation, and for the proximal lesion with a 3.0 balloon to 20 at 10 to 12 atmospheres. This is the result after predilations. I checked the IVUS, and by lumen distance, we selected the stent 2.5 to 26, which was implanted at 12
think,
atmospheres for 25 seconds.
I would suggest not to be too close to the distal bifurcation.
Bifurcation.
Yeah?
No, it is not. I will
Because
show-
my colleague Thierry said you missed the bifurcation, so don't do that.
I missed the
Either
bifurcation.
you cross, or either you enter the bifurcation. Then,
Right.
You see,
then you are going for 3 stents.
if this is the result.
Yeah, that's good. That's good. Excellent.
The problem is now,
Ostium of the LED.
the problem is the ostium of the LAD.
Can you go
And
to
I will show you.
spider with a
Yeah, that
more,
is-
more
I
LEO.
made a
More
lot of.
LEO, yeah.
They did.
So this is very illustrative spider.
You can
This
push
is
a bit
very,
more with
very
LEO.
deep spider. The problem here is that we have 2 angulations. In any case, I will ask for a second wire for the circumflex. And my question here is to the panel, should I go into the left main or to stand up to the ostium?
Let's go to the IVUS assessment, looking at the...
No, by IVUS is that you can nail the ostium for sure.
Okay, so you can try to be, let's say, to position just on the level of ostium,
Okay.
without
So,
penetration.
This is not my opinion, but you
I-
can have different opinions.
based on IVUS, there is a
Yeah, based
rationale
on
to
IVUS,
think
yeah, but
it's very difficult to be precise.
Right.
To
Exactly.
be on the ostium.
This is
what
the.
if you deploy the stent and you push a carina towards the circ, there is no way to bring back the diameter down. You know.
If I push the carina, probably that will be a temporary closure of this circumflex with this
No, don't do
angulation.
that.
You're putting a wire down the
Uh,
circumflex this now, Dobrin?
If you stand at the ostium, you create a lesion,
Integrity,
even if we
resolute
know
integ-
it's not always a tight lesion, but
Right.
creating lesion in the circ, then the only one option will to be stand from left main to circ,
Circ, yeah.
which is. But this is a
Like
distanting
a
beginning
reverse
with a
step.
side branch, and we know in this situation that we leave part of tissue which is not covered.
Always.
But then you'll have some drug illusion.
So, yeah, I did of course a lot of ostial stenting, yeah, but.
Dobrin is right because of the anatomical, let's say,
So I will-
situation. It's not easy to
Още сега.
to
No, it's
position
not easy. No, it's
to
not
to
easy.
position, let's say, the good projection for this ostium visualization. But you really wired the circumflex artery
Easily, huh?
as a champion of
Well, you taught him correctly. I
Дайте
think.
ми стенд.
universe.
Now, one method I have used to nail the ostium is to put a balloon down the circumflex, left main to circumflex, and use it to
3.1, medial
pull
to
the
medial.
stent back and see if it's
It's not
snug.
too big.
Yeah,
I will
understand.
place a
I
3.0
understand what you
stand,
say.
Yeah, it's right
and then
side.
we'll post dilate with 3.5.
No, you see, this is a medial to medial.
Ah, okay. Merci. So we will. We discussed with Akiko here that it is probably the best idea at the moment to place a 3.0 stent. And then I will do IVUS, and we will decide about the post-dilatation depending on the чакай малко, не бързай. Depending on the result. Добре, закачи се.
So, if you would have done crossover into left main,
Probably, yes. Yeah.
so Robert will nail the
This
This
ostium,
is my,
right?
you know,
Because of
sometimes,
the IVUS
IVUS.
images.
sometimes we can make
No,
the
that's too
exception
far
when
back.
the angle is really 90 degrees.
Yeah, then it's okay. Huh?
Yeah,
nice.
you can try to do, but
This is a very acute, kind of acute angle.
Okay.
With that movement,
Contrast.
for me that was good, let's say optimal position.
No, circumflex is
Okay,
But
so
this is still balloon
balloon, yeah.
outside the stand.
I think that
fine. It's
this gives a little bit more assurance for me about the jailing of the circumflex, and I feel that Dr. Nenov is a little bit agitated from the prolonged inflation of the balloon deflate. But
this is good. This is good.
but a short inflation and deflation is not enough. The stent is not designed just to expand in a moment. You need time.
30 seconds.
You need
at
time.
least.
Well, in this situation, we achieved around 17 or 18
Yeah.
seconds. 18. We'll
Can we
now
check it also with,
post-dilate.
with caudal views?
Отдой. And then
It's not bad, huh? It's not bad, but maybe.
now we will
in
do
front of
angio, and then we will do IVUS and after IVUS. We'll see.
This is good.
Looks fine.
This is good. This is good.
I expect it to be worse.
But it's crossed over, no?
I
Listen
think
up.
it's crossing over.
You just very
stand.
delicate touch the left main.
IVUS ми дайте,
It's
моля.
fine.
It's crossing over a bit.
Yeah.
Just a little.
We'll see with IVUS.
Yeah.
Will be interesting to see.
There is some pinching at the ostium of the circumflex.
Yeah.
Just a
But
small.
as I said, it is just impossible to place exactly the
And
Stand-
Akiko will tell us if the lumen, how is the lumen of the circ. We discussed
yes,
that.
I will
We
check.
discussed
I
that
will-
yesterday. That you push the carina, but you are not reducing a lot the surface. You are just
Absolutely
creating
agree
a
with you.
kind of crescent.
Can we give? Oh yes, we are. Okay.
This is
Okay,
a very
you are
good.
outside.
This is a very good sign.
Okay, can we start? Yeah, you can start pull back. Can you
Okay,
take? Yeah.
I'm starting.
Go ahead. This is super. Okay.
Disto, I will pull it
yeah,
a
yeah.
little bit
Faster.
faster.
Go ahead.
Yes, we are in the stand.
Yeah. Still, this is.
Can we see
This
the,
is-
the IVUS?
I just want to ask you for a few seconds of patience because logistics in the cath lab room is so that I'm obstructing the IVUS picture. Okay, so I'm in the catheter.
Okay.
Stop. Yeah.
Okay. Let's start from distal.
Yeah, stent
Can you
is-
see the IVUS?
Yes.
Okay,
Yeah.
so this is super distal. It's normal segment, done it nicely. And this is the edge, no edge dissection, good. And distal is, we can make it a little bit larger, but not too bad. That's how distal segment. Coming back, coming back.
It's well
Okay,
opposed.
still nothing.
Yeah, but
You could
Okay.
make it bigger. but-
This is originally
yeah,
normal
here it is
segment.
bigger.
Dilated, yeah.
Yeah.
Come back, come back. Okay, this is a calcified segment. The septa was okay. So this is this is original soft plaque segment, and then come back. That's a place you
Yes.
have the rotor, which having the
Yes.
trouble, and that's
Yeah,
a septa,
that's-
and that's the most significant portion. This is a proximal LED, right?
Yeah.
And go back, go back, go back, go back. This is a circumflex,
This is
which
slow.
was wire,
It's coming. It's coming.
and I
There's-
think you cross
nothing, huh?
over
The
the
stent
star.
is
Just one.
And this is a stent. And actually, this is a left main, I guess. And that's, so I
It is
think
for a very, very short.
few millimeter you are in the left main,
Left
I
main.
guess. Yeah. So I think you should open the circumflex portion. Or what do you think?
I will place IVUS there and we'll see.
No, the circle
Okay.
is okay.
Can we have from this IVUS an idea of the surface of the ostium of circumflex now?
Just I will place an IVUS into the circumflex. In general, if IVUS crossed the ostium of circumflex, I do not expect some severe
Nobody you will
compromise.
post
but
dilate, right?
We'll
The-
see. Just we'll see.
You're going to post dilate the LED stent, right?
Yes,
Yeah.
for sure.
Yeah.
Absolutely.
Okay, by the way, for now, the most significant place, minimum stent area is 6.4, which is actually good.
Yeah.
Okay.
You know what I really miss is let's say a second projection for orifice of circumflex and LED, because this is a shortening of the image. You
Yeah.
really don't see how deep we are in the left
I would
main.
say RAO with a lot of cranial.
Might be.
We
Let's-
separate
I
well
would
the-
separate it. Yeah.
It will not
I'll
cross.
take care. Oh, yes.
This is also a very good sign.
Yeah.
Very good sign.
Yeah.
Oh, great.
Okay, would you like to start? Pull back, recording?
Yes,
Go
let's
ahead.
go.
This is a circumflex. You see the completely normal. And this is actually small vessel. Nothing, normal, normal, normal. Now you see some plaque,
Yeah.
that's a disease. But that's not the current issue. So come back more. Still we are in the circ. We don't see the LED yet. And coming
This
back.
is the very ostium.
Yeah, not yet. I don't see the LED yet. Come back. This is calcified nodule, but still nothing. Okay, I think the LED is here. And you see, yeah. Yeah, really few
be
strands.
left main,
That's
yeah.
covering those
Can we
few
see?
strands.
Can we see IVUS, Akiko?
Yeah. Okay.
The biggest question for me is should I touch the ostium of the circumflex or not?
I think if we
we'll
have
see.
IVUS,
It will be-
will
Okay.
help us to
Can you
discuss.
see the IVUS?
Just a minute
Yeah.
to
sorry.
remove myself from the screen.
Moving on the IVUS will
So this is a proximal. Can you see the
be
IVUS?
okay.
Yes.
Yeah, yeah.
Okay,
yeah.
so this is a proximal circumflex. So then coming back here, here, not yet, not yet, not yet.
It's a small
And the
vessel.
top, that's LED. So this is osteocirc, which is eccentric lumen, and you see the LED stent was on the top of the circumflex, which is a little bit gel. And then we come back to the left main here, and already no more
So
strut.
I wouldn't
Can
touch
leave it like this,
circumflex.
yeah,
I
yeah.
So
wouldn't
I
touch
think very few
circumflex.
strut which
Yeah.
So the
covering
lumen
the,
of the circumflex is white, no?
Yeah.
It is not changed. Actually, it is
Yeah,
the same.
yeah.
Yes. Can we measure that?
Yeah, this is the osteostrut.
Just for the audience, living strut in front of a side branch
and actually you
is
can
very
push
current
the
in
IVUS
Korea for
Yes.
left main.
Yes.
This is
For
this is a
110
very
lesion
very
left
useful.
main.
If
So-
this I was passed.
Yeah, that's
And you see
meaning
this,
the big
this
lumen.
artery now is a bit oval.
For
was
me,
probably
this is a
pushed-
sign that I
Pushed
have.
by the
I should
You
not
have
touch
enough
it.
room there.
Absolutely.
No, you shouldn't touch it because you've
Don't
got.
touch. For me,
Дайте
don't
ми
touch.
пак 3 балона да NC2.
Because you have some disease at the ostium of the circumflex. If you
Yeah, but
dilate
that's
it,
almost endless.
you will
So
traumatize it.
the only option, in my opinion, is just to use a drug-eluting balloon
Correct, if you want
for
to do it.
circumflex dilatation, but you never know because
you
this
do-
is
it'll-
this is
yeah.
primary
Yeah.
lesion.
Yeah, if you have a dissection,
You never know what will be
Exactly.
the effect.
So leave it alone.
Yeah,
You'll maybe lose the drug
yeah,
during
exactly.
Oh, you mean trying to force it through?
Yes, and they will.
are you, Dobrin, do you think you are close to the end of your procedure?
I will do post dilation of the stent.
Okay, so I will move to the other
Yes,
rooms.
yes.
I will go back for the result. Okay.
Okay, okay, and then we will do our final IVUS and
Okay, I will go there.
Let's remove the wire,
Yeah.
the gel wire, and probably we are.
So Gianluca,
Yeah.
what have you done? Explain.
Okay, we stent the LED, we do the pot,
Yeah.
we stent the left main crossover, and now we are trying to pass a balloon into the left circle for pot side pot.
Okay. Can you show the
Yeah.
what
now
you
Valerie
did during?
show you the all the stuff.
This is the stent in
the distal lesion, yeah.
in the distal lesion, the bifurcation of the big diagonal. This is the stent after the expansion.
So
We did
for,
some pot.
for
with-
the audience, we have two diagonals. So following Ku,
yeah.
no ones need specific treatment.
No, we just selected the widest, just
Just
in
to
case.
keep it open, as
Yeah.
saying Antonio Colombo.
This is the pot with trio balloon. After that, we have a acceptable result in the LED, and we dilated the left main with trio. This is a non-compliant balloon. And the next is the result after the stenting. We saw it in another projection to see better the ostium. And now we decide for a stent into left main LED.
It's a 3.0 by 33 millimeter.
This is just precisely putting the stent. We move it a little bit forward. This is the place that we accept as a good position. A little bit of the overlap. This is the result after the stenting. This is 3.5 balloon. And this is the result after that. Then we crossed with a wire quite easily, but unfortunately we can see the crossing with the third wire. But unfortunately, probably it went under the strut stents, and we should, not we, but Gianluca should recross.
Yeah, we recross with another wire. I leave the wire I put previously there.
Maybe we can go in epicaudal,
Yeah.
and to be sure that we are in the right, I mean the guiding catheter is in a good place, just to allow us to
Let me ask you, Valerie, do you use the IVUS to mark the ostium? Because you can use the IVUS in a fixed projection and take a cine.
No, we haven't used IVUS. We wanted to make the work on the bifurcation of the left main, and after that we were going.
Yeah. No, I meant before you stent, to know where the ostium is, you can use the IVUS to identify the ostium.
Yes, that's a good option, but finally we can see clearly from left cranial that it is in a good position. Still, we have a very...
It's so short, the left main, that putting the sitting the guy catheter properly, even if it's a short one, because it's an ABU 3.0, it's not easy.
Gianluca, have you performed a pot in this very short left main?
Yeah. We do a pot with a 3.5 by something.
By 15, but
by 15.
This is.
And you think you were out of the stent?
Yeah, this is the last one.
With the wire, you think you were out of the stent or not?
Of course, it was just proximal, just in front of the carina, and the rest of the balloon was outside the aorta. So.
Yeah.
No, it's not.
No, it's not good, I think.
To pot again, I think.
Maybe this is again outside. Probably we should go.
What you can do is redo a pot with a bigger balloon.
Yeah.
That's
yes, that's a good option.
On the LED wire, and we'll solve the problem.
No, I mean if we can push the wire in the LED deeper, we can redo the pot, and after that over the balloon.
You have a wire in the LED, so.
No, I mean to put it a little bit distally, and doing a pot after that over the balloon to cannulate the ostium of the left main, still with the balloon inside of the vessel.
The LED wire was not moved during the procedure.
But we haven't discussed your choice in terms of stents. What stent you used?
This stent is Science.
Yeah.
It is 3.0, and this is what we found on
By IVUS.
by IVUS, because 3.0 is the diameter media by 2 media.
Media to media is 3.1.
3.1,
Yeah.
3.8. Yeah.
But by the way, I have the question to Akiko. You have right now the IVUS diameter for LED proximal and circumflex proximal. Please calculate by Finne formula, the size for left main, because I'm pretty sure that 3.0
What's the diameter of the circ? What's the diameter of
not
LED?
enough.
Yeah, I agree. The diameter of the proximal LED is 3.6 and 3.3 by media to media.
That's 7.
And, and the left main is also media to media is 3.1 and 3.6.
And the circ? You don't have the circ?
No, we don't see the circ, but you are right. Comparing the LED and the left main, the size-wise, they're actually similar. So
so that's 7 millimeters. The sum, 2/3 will be 4.5.
3.5.
At least 4. At least 4.
4.5.
Yeah.
So probably a pot with a 4.0 at relatively high pressure will solve the problem of crossing outside the stent.
Yeah.
Mathematical.
Calculated?
4.7.
4.7. Yeah. So the calculation here is 4.7 for the pot.
Yeah, to buy a glass.
Let me
Some glasses, yeah.
assist you. Novacqua.
We don't hear you anymore.
What?
We don't hear you anymore.
No, I'm just...
We are concentrated.
Okay.
Yeah. Can we go to the other room?
Yes, of course. We are just trying to...
We'll see the end of the procedure in the other room.
14 millimeters.
Then 14. Yes, it is. Yeah, it's very short.
No, but
Dobrin,
Uh-huh.
Have you finished?
No, I'm finishing slowly.
That's much better.
Much better, yeah.
Yeah.
This is after
That's,
post-dilatation.
Depending
that's,
to the
that's
LED.
almost
After this
osteo LED.
dilatation, it's
Yeah.
This is
much
a place
longer
we
than
had the
it was.
trouble.
It's
It's
not already
better, I
short.
think.
Yes, I post-dilated up to 22 atmospheres.
Okay, that's a circ.
Yeah.
I think it's good.
Yeah, it's good. Okay, stop.
Okay, well, can you show what you did? And Akiko, can you describe the IVUS as it is now?
I bet sure. Andrew, which one?
No, you.
Okay.
You first.
Okay, so let's start super quickly. Actually, it's much better than before. So this is a very distal edge and
Yeah,
no edge
here is the stent.
dissection.
Yeah,
And then you see visually, the stent was much better everywhere, looks
Yes.
larger to me compared to the last time. And they come back, everything is better, and now it's well expanded. So let's go back to the most important, which is the original region, which is here. So you remember this is a septa, and this is just distal to the septa. Starting here, that's the calcium. And then proximal to the septa where the soft plug was, and then somewhere here where the rotablator is necessary, meaning like stuck portion. So now this is much better. Last time it's 6 point something, but now it looks like better. Okay, so this is the osteo LED, and then we come back. You see the circumflex
Yeah,
in
yeah,
the
yeah.
6 o'clock, and a little bit crossover, but we put in the IVUS
Yeah,
into the
this is
circ
better.
directly,
Even
so we
with
think
better,
that's not
with
much.
better
and there's the left
let's say
main.
lumen,
Good.
because
Good.
there was a spasm.
I think it's good.
If Akiko says that it is good,
So,
I'm pretty sure that...
Anangio, please.
Yes, we will do it now. We close the eyes and remove everything. This is the usual strategy before the final shot. Okay. Cine?
Yeah,
Yeah.
circ is
Yeah, it's
well
very
open.
good, very good.
It's good. It's good.
We will do also
And-
the
and
cranial. Okay. Go. Well, I'm satisfied.
We too.
Me too. Yeah.
Congratulations.
Thank you.
Nice.
So see you later. We'll go back to the first room for the end.
And then put the bone just in front of the,
So what have you done, Gianluca?
if it goes from down up into the, oh, now pull a little bit.
So we have to remember that,
Push it
especially with
distally and now
so-called
push the
aggressive
guiding a little bit.
guide
But the
catheters,
wires have to.
we have to be very cautious
Oh,
not
it's
to
nice.
touch, not
And when
to
you pull out
destroy
the bone, it will
stent
sit in
implanted
front of
in
the
left main
left
because
main.
of this longitudinal
Yeah.
stent
Distortion.
distortion.
Yeah.
You have to take care. In Excel trial, the study was made by Akiko Maehara. She found, I think, 8% of longitudinal
Up the wire
distortion.
in the LED.
And it has an influence on the mortality.
Yeah.
So
Yeah.
this is something, probably because most of them were not
should
detected
be,
by the operator.
Priberius, yeah.
But even detected, you have to restent, you have to, this is
Добре, дай сега приготви двойката.
Did they part again, Robert?
Sorry?
They parted? Did
They
they part
pat.
again or no?
No,
I didn't see.
Okay,
Gianluca, did you
Yeah.
have you redilated?
Yeah, we redo a part high atmosphere 3.5 by 8 at 18 atmosphere.
yeah.
And we reassess to the circuit that it was not difficult, but anyway, we couldn't pass the balloon before. So now we hope to have.
Another reason for not crossing, which is today much not frequent at all, is the crisscross of the wires.
Yeah.
If you take two more rotation of the wires to penetrate.
Yeah.
Right.
That's
So
the
that's
reason
why I was
we
recommending to
remove
my
all the
fellow
wire.
to turn
Now
with
we are
the
good.
wrist, They cannot turn 10 tours.
No, it's going.
It's good now. So
Okay.
I think this is important to remember this. If the balloon is not going, that there is a good reason not to
how
go.
many-
So
Yeah.
you have a wire which was here from the beginning, you put and you recross, you are in the lumen and not outside.
Even if you are very aggressive with the balloon, you can again distort the stent.
Yeah, of course.
3.5.
Right?
This one or?
And
or
if
no?
you're
No, I
behind
think
it, then
this
it's
one, no.
even worse.
I'm more confident that we go there. The problem is that it's small. The short is small.
So you are doing pot side pot, you said.
Yeah,
Pot side pot, yeah. So
I
pot
am
was,
in favor of
pot was
side
done, you have
pot
to do a
rather
second
than
pot now.
kissing.
yeah.
I usually do not do kissing in crossover stent because we have data from my center we have published in the past that is for the outcome kissing when you are only
David,
crossover is worse than do a pot side pot. So or a pot
I
only.
would say it depends probably of the nature of the kissing. What I try to do is to have overlapping of the two balloons only in the polygon of confluence.
Yeah, sure.
Yeah.
So I think he solved the problem. And the advantage of kissing is to have
But from
to put the carena in the position.
From physiological point of view, when we approach this kind of problem with the computation flow
triple.
dynamic, and
Sorry, give us
and
triple.
no,
The
and
3.5.
and we saw that when crossover to do a kissing does not improve the washer stress forces to the carena compared to pot only or pot side pot. So I was convinced that from that studies that we do some years ago that probably the most physiological thing to do when the pot is well done. I mean, if you do a wrong pot, you are forced to do a kissing. But if the pot is well done, from a rheological point of view, side pot is better than kissing. That's my view.
Ай сега.
Станка?
So we have to
Малко
remember that
маската да извалиме. Маската да извалиме.
Okay.
А давайте подлога, подгответе.
If they reuse the one or...
Yeah, wire is probably twisted.
Okay.
Ей, сега.
Difficult, huh? Okay.
Давай.
the wire is across the balloon, so deep is twisted.
11, 18.
Not there's only one.
Okay,
There's
stop.
only one.
Twisted, but maybe one after 2 hours is not a problem. In the past with all stent, having twisting
That was the
was a catastrophe.
Okay. So we perform the final part. Now we check for hivers, possibly. And we will have some of the answer to our
It was
question. We
disconnected
do
from the...
a good one
Yeah, let's
or
do the
not.
quick pullback. Can you push
The pot
this,
is proper or
this,
not. The
Yeah.
carena
this?
is
Okay, perfect. 2.5, quick car.
well opposed or not.
Pullback.
Running. Running backwards. Давай.
So it's worth to stress
I like the quick
that
one.
when we have so-called
It's like OCT.
short
Yeah, too slow.
left main, the visualization after stenting with angiography is very, very complicated. And then only IVUS assessment can let us stop or finish the procedure. Anyway, I don't like this opacification of left main.
Yeah, but it's not possible. With the
So
balloon is long, you have to remove.
So we need
Yeah, I
IVUS. This is not.
I think we can stop here. Okay.
I wish them to
You are
get
still in
the
the stand.
good
But
result.
we have some difficulties because
Oh,
of the
okay, okay.
duration.
Okay, so
I think
let's
we
start.
can.
Positive over there, I don't know. want to
Okay,
touch.
okay. Let's start from here. Okay. This is somewhere in the LED. And putting back. That's the proximal LED. And that's the circumflex. And this is the
it
left
looks-
domain. And nicely cover. Good.
Yeah,
Okay.
very
looks
good.
good.
There's
Perfect,
some
perfect.
protrusion
So
into
I
the
think
left main.
we have
it's-
done,
But on
and
one
we
side,
shot.
yeah.
of
It's
course.
always
That's good. Yeah,
right.
that's good. That's
Yes,
good.
you
That's
are
good.
done.
Yeah.
You have done.
I don't think you need another angiogram.
What?
But there was not
Let's
let's say
go.
optimal
Okay.
position
And
Where?
what is the minimum
in the
stented
distal
area
part
of
of
the
the
left main?
Left main?
let's say left main, just before the
Let's
circumflex
check where
orifice.
Kiko.
Are you talking the left domain minimum stent
Show
area,
us.
which is going to be, I'm a little bit generous.
You mean by
We are
7
checking
point-
the IVUS for you.
But
7.2.
show us the
Show
That's
the
okay.
IVUS, please.
That's,
Yeah, yeah.
that's the left domain, 7.2, that's a minimum. But remember, this patient is relatively small left domain.
Yeah.
I think that's what we can do, right?
Yeah.
And importantly, if you come back, you cover nicely
Yeah,
and
you are
want
in
to
yeah,
the
that's good,
strap.
but
Uh,
go to the LAD.
Okay,
Please
okay,
go to the
sure,
LED.
sure, sure. Okay, so that's a proximal LED.
Yeah.
Coming back. This is a osteo
There's
LED.
this-
Okay, if you
Yeah.
want, see how big the osteo LED is,
Yeah.
6.6. That's really good. And that's the top
That's
is
the
the circumflex
bifurcation.
osteo, and widely open, and then nicely transitioning to the left
But
domain.
then there's a lack. There's a between 12 and 9. Go back. Go back. Now
I'm sorry,
back
what?
to. Go back to
It's
LAD.
okay.
Go back
Anyway,
to LAD.
perfect.
Kiko, tell me that is perfectly okay. So
Okay.
No, but
Yeah.
we have
I would
stent,
I
which
would
is,
suggest
more
to
than
use a
double,
bigger balloon for zero.
the minimum
What?
stented area. So it's
Just look at the IVUS. Look from the beginning of the
okay,
stent,
let's make
going towards
one cranial.
LAD slowly, but not from LAD, but from orifice of left main.
Sorry.
Just go back a little bit
have to learn.
because that was the point. Okay, okay.
I have Philips.
Slowly,
Yeah, back,
slowly, back,
Okay.
back.
Let's-
No, back,
That's already-
back.
No, the reason is that we
Slowly.
use it.
Yeah, yeah,
You see,
yeah, but
you see.
That's
So-
circumflex.
So, in my opinion,
I think
this is a very good result, of course, but still I would say that the left main is 4.
A posto?
But okay,
Abbiamo
it's,
finito, eh? Finish. Right? Okay.
Okay, let's remove
okay,
the
good job. Good job.
Okay,
Thank you very
All
much.
right, good.
Пишкаш екстра стана всичко.
she knew that.
So,
Сложихме
we are nearly on time. Huh?
2-3 стент.
Just 10 minutes late.
Oh, that's
So this is the end of the session, and I think this is the time I need a coffee. So I have to go to the